This is part 3 of the Pathophysiology lecture. And in this section, we're going to talk about hypoperfusion. Perfusion is the delivery of oxygen and nutrients and the removal of wastes from the cells, organs, and tissues by the circulatory system. Adequate circulation is dependent upon a pumping heart, intact vascular system, and the appropriate amount of oxygen-carrying blood. A deficiency in any of these areas will cause problems with perfusion, and we know that, right? So if the heart's not pumping well, we can have a cardiogenic shock. If we don't have an intact vascular system, we could have a distributive shock. If we can't get the right amount of blood, we might have hypovolemic shock. So all of those things need to be in place to have the appropriate amount of perfusion. And hypoperfusion occurs when the level of tissue perfusion decreases below normal. So when the body senses tissue hypoperfusion, it first sets a compensatory mechanism into motion, or several compensatory mechanisms. One of those might be an increase in your heart rate or peripheral vasoconstriction, and that's to maintain adequate blood flow and perfusion to your vital organs. And you may be able to maintain an adequate blood pressure and an adequate level of perfusion for a period of time, and we call that compensated shock. But eventually you go into decompensated shock when you can't keep up. Your compensatory mechanism just can't keep up with the demand. Let's say if you have hypovolemic shock, there's just too much blood loss, so on and so forth. So that's sort of the brief definition of perfusion and hypoperfusion. So we're going to talk a little bit more about hypoperfusion. Okay, and your body's going to respond to hypoperfusion in many different ways. Some of these you may already know. One of those important ways is the release of catecholamines is going to be the first thing, right? Release of catecholamines. And that's going to be your epinephrine and norepinephrine, or norepi, sometimes called noradrenaline. That's Levophed in drug form, right? And epi is adrenaline. And obviously you're going to get a lot of alpha, a lot of beta. You're going to get increased strength of cardiac contraction, which is a positive inotropy. Increased heart rate, which is positive chronotropy. And vasoconstriction. And what we're trying to do is we're trying to act on that blood pressure formula, BP equals cardiac output times systemic vascular resistance, or sometimes called peripheral vascular resistance, depending on where you read. Cardiac output, we know, is a product of heart rate times stroke volume. And the systemic vascular resistance, that's got three factors. One of it being the lumen, the size of the blood vessel, or the lumen of the vessel, if it's dilated or constricted, right? Another being volume, and that's different than stroke volume. Stroke volume is how much volume comes out of the heart with each beat. This is overall volume in the body. And then the third thing is going to be viscosity. Viscosity. I think I'm spelling that right. Viscosity. And viscosity has to do with the thickness of the blood. Is it more water-like? Is it more tomato paste-like? Okay, and that's how we get an increase in blood pressure, some sort of effect on cardiac output or systemic or peripheral vascular resistance. And epi and norepi, we know it causes vasoconstriction, so it affects the lumen. Okay, it's going to change colors here. It affects the lumen, and then it's also going to increase heart rate and increase stroke volume. So increasing all those things, you increase cardiac output, you get an increase certainly in peripheral vascular resistance, and then we're going to end up with an increase in blood pressure. Okay, so that's what we're trying to do. We're trying to affect this equation when our body is compensating. The other way your body tries to compensate is the activation of the Reninangiotensinaldosterone system, sometimes called RAS. And I'm going to talk about that in the next slide more in depth, because that's a very important concept. We also have the release of the antidiuretic hormone. In drug form, that's vasopressin, is what that is. Antidiuretic hormone it's a potent vasoconstrictor, but also it eliminates diuresis, or it tries to stop diuresis. It's like opposite of Lasix, if you want to picture it like that. So you're trying to keep volume inside the body. And why is that important? Because we know, if we look at our equation down here, if you increase volume, you're going to end up increasing blood pressure. Okay? So that's what your ADH does. Then your body will also try to shift fluids from outside of the blood vessel. So let's say this is a blood vessel, and it's going to try to shift fluids that are all out here in the tissues back into the vessel, all right, into the vascular compartment. So if we push fluids from our body, because there's fluids everywhere, right? You have extracellular, intracellular, intravascular, extravascular. You have fluids everywhere. And that interstitial fluid, which is extravascular, is trying to get back into the vessel. And what that'll do is increase the amount of volume in the blood vessel, okay? And then it'll also increase stroke volume to a certain extent, and that will increase blood pressure as well. So that's another compensatory mechanism that we have to try to maintain perfusion. The overall response from all of these things is an increased preload, increased stroke volume, increased heart rate. And of course, we know that there's going to be peripheral vascular constriction, which is an increase in systemic and peripheral vascular resistance. All right, let's talk about the renin-angiotensin-aldosterone system. Let me just make that bigger. Okay, and the renin-angiotensin-aldosterone system is a complex compensatory mechanism within the body. Your body picks up that there's some sort of problem with blood pressure, with that hydrostatic pressure inside the blood vessel. And you have baroreceptors that pick that up. You have baroreceptors in your aortic arch and the carotid bodies of the carotid arteries, and those baroreceptors will signal the brain to start this process. Along with releasing catecholamines, of course, you begin this renin-angiotensin-aldosterone system process. And what happens first is your liver is going to secrete angiotensinogen. Angiotensinogen is not going to do much, but now you're secreting it, okay? You're secreting it into the bloodstream, into the body, and your kidney, at the same time, okay, is going to secrete renin. And the renin is in response to a decrease in arterial pressure in the kidneys, a decrease in sodium in the blood, an increase in sympathetic tone. Any of those things are going to cause the kidneys to secrete renin, all right? So we know that we talked about, all right, our pressure's down, so now renin's being secreted. And the importance of renin is now that angiotensinogen that isn't doing anything, okay, when renin is there, it can actually be converted into angiotensin 1. All right? Angiotensin 1 is important because in the presence of ACE, angiotensin converting enzyme, which comes from the lungs and then some epithelial tissue, and the blood vessels will start secreting ACE. And angiotensin 1 in the presence of ACE becomes angiotensin 2. Okay? And angiotensin 2 is super important because that is one of the body's most potent vasoconstrictors. It's a very potent vasoconstrictor, okay? Now, the other part of this renin-angiotensin-aldosterone system is aldosterone. And aldosterone comes from the adrenal glands, okay, over here, the adrenal glands. And what's going to happen there is it's going to tell the body to not let so much sodium be secreted, right? It's going to tell the body, let's keep sodium within the blood cells, and that's going to cause fluid retention, all right? So we're increasing volume. We know that will increase our overall blood pressure. Angiotensin stimulates sodium and fluid retention in the kidneys. Okay, so even before we get to angiotensin 2, we're going to stimulate some sodium and fluid retention in the kidneys. Angiotensin will also stimulate muscle hypertrophy and fibrosis in the heart. So it'll make your heart have a thicker muscle that will beat, help it beat faster and harder. Angiotensin stimulates sympathetic outflow in the brain. We know the sympathetic nervous system is where we get our catecholamines, epinephrine, norepinephrine. And then angiotensin stimulates vasoconstriction in the blood. Remember, angiotensin 2 is the body's most potent vasoconstrictor. So all of these things are going to cause a stepwise increase in blood pressure. And this is kind of how we get congestive heart failure. I don't want to get too far into CHF, but somebody develops heart failure. Let's say they had a bad myocardial infarction, so the heart's not effectively pumping. The blood pressure goes down. Your baroreceptors pick up on that, and it starts excreting. Of course, you start excreting your catecholamines, but you're also going to excrete ADH from the pituitary gland, and then also your renin-angiotensin-aldosterone system is going to kick in. And that's what happens is all of those things go into place. Now you have fluid retention. You have very potent vasoconstriction. And you have increase in heart rate. You have thickening of the heart muscle, and the heart becomes stronger, which isn't always a good thing because we know that all of those things affecting the blood pressure, eventually your blood pressure is going to get too high, and it can cause congestion in the lungs and systemically with edema. So that's why all of these medications exist. So you can actually block the renin-angiotensin-aldosterone system by blocking renin. So if you block renin, angiotensinogen won't become angiotensin 1. And the medication that does that is Eliscarin, or Tecturna is the brand name. Okay? Or you can block ACE. This is a very common one, ACE inhibitors. So lisinopril, enalapril, all those things that patients are on are ACE inhibitors, all the prils. And if you block ACE, angiotensin 1 won't become angiotensin 2. If you block that, then you don't get all this vasoconstriction, you don't get that extra stimulus of the sympathetic nervous system, and you'll slow down the hypertrophy. And that's a good thing, obviously, if they're having too much compensation with those things. And then there's ARBs, where you actually just block the receptors for angiotensin 2. And you may be familiar with some of those. Cozar is a common one, Diovan, Micardis. Those are all the brand names. Any of the trade names, the generic names are going to have the suffix sartan. So one common one is losartan, that's Cozar, or valsartan, that's Diovan. And if you block the angiotensin 2 receptors, then of course you're going to block some of this effect. And we remember how antagonists work when they block receptors. They don't block all of the receptors, but now you're a competitor in that bloodstream. It's going to compete for those receptors. All right, so that's the renin-angiotensin-aldosterone system. We're certainly going to talk about that more when we get to some of the different pathologies that involve the renin-angiotensin-aldosterone system, especially CHF. But that's a brief overview right there. So hypoperfusion persistence results in continued increase in myocardial stress. So persistent hypoperfusion results in a continued increase in myocardial stress. The compensatory mechanism can no longer keep up with increased oxygen demand, and then you'll get worsening of myocardial function. Tissue perfusion will decrease, causing impaired cell metabolism. Fluid may leak from the blood vessels, causing systemic and pulmonary edema, and then other signs may be present, such as dyspnea, dusky skin, low blood pressure, oliguria or anuria, which is the lack of urine production, and then an impaired mentation or altered mental status could arise as well. And that's when you're in decompensated shock. You're going to have some of these things, and you can end up with organ failure as well. So shock is an abnormal state associated with inadequate oxygen and nutrient delivery to the metabolic apparatus of the cell. This is a very technical definition. It's the same thing as hypoperfusion. It results in impairment of cell metabolism and ultimately inadequate perfusion of vital organs, prevents the body from properly using oxygen and glucose at the cellular level. And we know that's where we get energy from, ATP. Cells revert to anaerobic metabolism instead of aerobic. So anaerobic metabolism is metabolism in the lack of oxygen and glucose, and that creates an acidotic state. You know that you're going to get an increase in pyruvate, which ends up becoming lactic acid, and you'll end up with a metabolic acidosis. Glucose impairment leads to elevated blood glucose levels due to a release of catecholamines and cortisol. All right, so your blood glucose levels are going to be altered as well. We're talking about shock. There's 4 main categories of shock that I want you to remember. And depending on where you read, it'll tell you 4 categories or 6 categories or 10 different types. But you can get all of the different types of shock into these 4 main categories. You have cardiogenic. Cardiogenic shock is going to be caused by dysrhythmias, by myocardial infarction, heart failure, that kind of thing. And that's cardiogenic shock. One of the key indicators of cardiogenic shock is hypotension and the presence of pulmonary edema. Hypotension with pulmonary edema should be considered cardiogenic shock until proven otherwise. Next, you have obstructive shock. Obstructive shock is anything that obstructs the perfusion, and a lot of times it's going to be something like a pulmonary embolus, okay? A pulmonary embolus is a clot within the lungs, the vasculature of the lungs. And if you look here at this image, we have capillaries around the alveoli in the lungs. And if you start blocking that, you can block the exchange of oxygen and CO2, and the patient could eventually become hypoxic. And hypoxia is a type of shock. So that's one form of obstructive shock. Another form of obstructive shock would be cardiac tamponade, where the sac around the heart here, okay, it has too much fluid in it, and it makes it difficult for the heart to expand and to fill up with blood. All right, that's another type of obstructive shock. And another one would be a tension pneumo. Okay, so you have a hole in the lungs, and then you get increased pressure in the intrathoracic cavity. All right, and that increased pressure in the thoracic cavity will push down on the heart, and again, you won't allow the heart to fill up with blood. And the hallmark sign of a heart that can't fill up with blood is JVD. You'll see those blood vessels sticking out up in the neck. Okay, so those are obstructive shock. And then you have distributive shock. Distributive shock involves the blood vessels. Okay, you might have enough volume, but your container is too large. All right, if you look here at these blood vessels, if I were to take all these arteries and dilate them, make them very big, all the arteries in the body, okay, then your blood pressure is going to go down. Okay, just like when you cause vasoconstriction by giving a vasopressor, you're doing it to increase the blood pressure. If we dilate the arteries, like we do with nitro, when you administer nitroglycerin, you're going to decrease the blood pressure. And that can happen with distributive shock. And the types of distributive shock are going to be sepsis, so septic shock, anaphylaxis, anaphylactic shock, and then neurogenic shock. Okay, and those are the three types of distributive shock. So with septic shock, you have a systemic inflammation. That systemic inflammation causes your blood vessels to dilate, right? Because that's where you get your warmth from, the dilation of the blood vessels from that systemic inflammation. You also get leaky membranes, and that's where you get edema and fluid shifts and those sorts of things. And fluid will shift out of the blood vessel, unfortunately, which means they need volume replenishment. With anaphylaxis, same thing. You get a lot of urticaria, for example, is a sign of swelling, and it's also a sign that you're leaking fluid, right, out of the blood vessels into the extravascular space or the interstitial tissues. You also get peripheral vasodilation with anaphylaxis. That's why epinephrine is such a good medication for that. And neurogenic shock. With neurogenic shock, you get loss of sympathetic tone. And remember, sympathetic tone is what causes your vessels to constrict, right? So if you lose sympathetic tone, then your vessels won't be able to constrict, and your heart rate may be lower as well. And how you get neurogenic shock is like a spinal cord injury. So if somebody had a lesion to their spinal cord or lacerated spinal cord or some sort of bad neck injury, they can end up with neurogenic shock. So septic shock, anaphylactic shock, and neurogenic shock are all types of distributive shock. Distributive shock means the container's big and there's not enough volume. And then finally, we have hypovolemic shock, which most people know what that is. You can have two forms of hypovolemic shock. One, where you bleed, or two, where you're dehydrated. You don't have enough volume within the body. Okay, so obviously if your volume goes down, you can't maintain that blood pressure equation, and your blood pressure will decrease. So shock can occur due to inadequacy of central circulation or peripheral circulation. Central circulation or peripheral circulation. Cardiogenic shock occurs when the heart cannot circulate enough blood to maintain adequate peripheral oxygen delivery. It's a type of central shock, and we said there's 4 different types of shock. Well, 2 of those, cardiogenic shock and obstructive shock, are both central shock. All right? So the most common cause of cardiogenic shock is going to be a myocardial infarction. That's going to be your most common cause of cardiogenic shock, especially like a right ventricular infarction. And we'll talk about that later in cardiology. Obstructive shock, we talked about, occurs from maybe a pericardial tamponade, a tension pneumothorax, or something like a pulmonary embolism. And with the pericardial tamponade, you get diastolic filling of the right and left ventricles is impaired due to that significant amount of blood that's in the pericardial sac around the heart. And that most often occurs from trauma, but it could be due to infection or something like that as well. You'll get decreased ventricular filling associated with pericardial tamponade, and leads to a decrease in the overall cardiac output, like we talked about. Aortic dissection can also lead to a false lumen with loss of normal blood flow. So aortic dissection can cause an obstructive shock. A left atrial tumor, all right, which isn't that common, but it could cause an obstruction of flow between the atrium and the ventricle, and this will decrease cardiac output. Obstruction of either the superior or the inferior vena cava decreases cardiac output by decreasing venous return. And then, like I said before, a large PE, pulmonary embolus, or a tension pneumo may prevent adequate blood flow to the lungs, resulting in inadequate venous return to the left side of the heart. So all of those are different types of obstructive shock, and then obstructive shock and cardiogenic shock are both types of central shock. Then, of course, we have peripheral shock, and then hypovolemic shock is going to be your most common type of peripheral shock, and blood is unable to deliver adequate oxygen and nutrients, right? Kind of goes without saying. We know that's true. Circulating blood volume is insufficient to deliver adequate oxygen and nutrients to the body. There's two types, exogenous and endogenous, and external bleeding is the most common type of exogenous hypovolemic shock, and then endogenous shock occurs when the fluid loss is contained within the body, such as dehydration, okay? Or you could have fluid shifts that could cause hypovolemic shock and things like that. Sometimes patients may present like they have a fluid overload because the fluid is not in the vascular space. They're third spacing fluid into the extravascular space. And that's a very difficult case because they look like they're overloaded with fluid, but really they're vascularly dehydrated. All right, let's talk a little bit more about the management of shock. Most types of shock are characterized by reduced cardiac output, circulatory insufficiency, and a rapid heartbeat. Determining the presence or absence of shock requires the evaluation of the presence and volume of the peripheral pulse and assessment of end organ perfusion function. So some of the things I tell you there, when you're actually feeling for a pulse, feel for the strength of the peripheral pulse. It's related to both stroke volume and you're going to get that heart rate, and an increased heart rate tells you that they're probably compensating, right? So you want to know if it's a bounding pulse or if it's a weak pulse and where. So you compare your peripheral pulse to your carotid pulse as well. A normal skin perfusion results in warm, dry, and pink extremities, the fingers and toes, but if you notice decreased capillary refill or pale extremities, obviously those are signs of shock as well. And shock may result in slow, delayed, or prolonged capillary refill, as I was saying. They may have normal capillary refill initially where they're maintaining good compensation, but then eventually you'll start noticing pallor, distally, mottling of the skin, peripheral central cyanosis, delayed capillary refill, again, is a huge signal of presence of shock. And then measuring end-tidal carbon dioxide, so ETCO2 or capnography, is also very useful and tells you a lot about the patient's overall circulatory status. So interpret the effectiveness of perfusion based on changes in capnography and capnometry as well. Decreased levels of end-tidal CO2 are an early indicator of shock, and low levels of end-tidal CO2 combined with your other signs and symptoms of shock, of course, such as altered mental status or hypotension, they're ominous clinical findings. So if you start seeing an end-tidal CO2 drop below 35 on somebody that you suspect is in shock, that's an ominous finding, and they could be in a lethal condition. We know that with septic shock, when we start seeing lower end-tidal CO2 volume, they may be a sepsis alert. Okay, so it is a very good tool to use as well as all of your other vital signs. Just reiterating, measuring end-tidal carbon dioxide may be useful. Interpret the effectiveness of perfusion based on changes in capnography and capnometry. And like I said before, decreasing levels of end-tidal CO2 are an early indicator of shock, and low levels of end-tidal CO2, when you combine it with everything else you see in shock, it could be an ominous clinical finding. So here we have decrease end-tidal CO2. And again, your patient may be hyperventilating. That's another cause for decreased end-tidal CO2. But if they're hyperventilating and they don't have good circulation, let's say they're hypovolemic, then it'll be even lower end-tidal CO2. So keep an eye on it. It's a good assessment tool. And with that, we've come to the end of part 3, talking about shock. Just keep in mind that equation: blood pressure equals cardiac output times systemic vascular resistance or peripheral vascular resistance. All right. And all of the things that affect that, your body's compensatory mechanisms, and even how your compensatory mechanisms can become too much in chronic conditions. The compensatory mechanisms are really good for acute transient conditions. You get dehydrated for a short period of time, your body compensates very well for that until you rehydrate. However, for more chronic conditions like heart failure, your body overcompensates. You start, again, with that renin-angiotensin-aldosterone system, all the catecholamines, the release of ADH, all of those things in combination can cause, like we've seen before, pulmonary congestion with pulmonary edema, distal congestion. It can cause kidney failure because your kidneys are working extra hard, or you're not perfusing them enough is another way to look at it. And they have to be put on all these medications to block the renin-angiotensin-aldosterone system and cure some of the effects, like Lasix to cure some of the antidiuresis. All right, so keep that equation in mind because that's probably one of the most important things to remember when it comes to shock.